Welcome everyone. I see people still filing in and joining the Zoom, but I'll go ahead and get us started for today's brown bag seminar for the Department of Global Health and Population. Welcome to all of you that have joined. It's our pleasure today to welcome Dr. Eric Nilles, who is Director of the Program on Infectious Disease and Epidemic at the Harvard Humanitarian Initiative. He's also Assistant Professor at the Harvard Medical School and an attending physician at the Brigham Emergency Department. He's worked in more than 30 countries for MSF and WHO on disease outbreaks and humanitarian emergencies, including in settings like Darfur, DR Congo, Chad, and many others. And today he has expertise in early warning disease surveillance, outbreak response, and many other related topics. And today we're very lucky to have him here for our seminar to talk to us about rethinking emerging pathogen surveillance. So thank you for coming, Dr. Nilles, and I'll hand over the Zoom to you.
All right, great. Thanks very much, Kevin. Good afternoon, everyone. Yeah, I'd like to talk a little bit about one of the projects we're working on and taking the data from that project and using it to sort of reconsider surveillance in the time of COVID and COVID variants. So as you see, the title is Integrated and Hopefully Pragmatic Real-Time Clinical, Genomic and Immunological Surveillance for Emerging SARS-CoV-2 Infections. So a brief outline of the talk. So I'll provide a little bit of detail about the IDEP, or the Infectious Disease and Epidemics Program at HHI that I direct, but mostly talk about this integrated surveillance approach. Run through the background, methods, findings, and then I have a few points in the conclusion. So here is the IDEP program, and around the outside are the sort of some of the main activities and projects we're working on right now. So the first one is acute febrile illness surveillance in the Dominican Republic. So this is part of a CDC U01 award, 2018 to 2024 now, actually. So we enroll patients at 2 large health facilities that present with undifferentiated fever. We collect nasopharyngeal swabs, blood, administer questionnaires, and test for a range of pathogens, influenza, COVID, a number of arboviruses and leptospirosis. We've enrolled a little bit over 3,000 patients over the last about 2 years and some. Seroepidemiology, so we do quite a lot of work in this sort of area, this space. Prior to coming here, I worked on a number of national serological surveys, and we just completed a large survey in the Dominican Republic. We enrolled 7,000 participants from about 3,000 households across 132 clusters in all of the 32 provinces in the country. So pretty sizable logistical operation. This was from July through beginning of October last year. We had 10 teams in the field for about 3 months. So it was complicated, especially during COVID times, but very happily we got that wrapped up. And the first manuscript actually is out. So we're also testing for a range of pathogens. The initial focus was on SARS-CoV-2, I guess obviously, but we're testing for arboviruses, dengue, chikungunya, Zika virus, Mayara virus, Mydiaraja, leptospirosis, and several others. But as I mentioned, the first paper was just actually published. This is the title down here at the bottom, in Lancet Regional Health Journal, just a few days ago, actually. We also work on water and sanitation issues in Dominican Republic. We actually established 2 alcohol-based hand sanitizer production units in the 2 hospitals where we work. We produce it, we distribute it, monitor the use. We monitor hand hygiene adherence, conduct education campaigns, etc. This is a bit of a rapid fire just to provide an overview of the projects, but happy to fill in with any details later if of interest. We have an ongoing randomized trial of home-based care for COVID patients, so COVID patients in Honduras, in the capital Tegucigalpa, who have COVID, are confirmed with COVID and are at high risk for serious outcomes, but are being sent home, are offered enrollment into this study. We're assessing pulse ox devices, pulse oximetry devices, and a lot of it is around sort of the feasibility of this approach. We've enrolled about 1,300 patients so far. A little slow now because there's not a lot of transmission, which is good for the country, but not so good for enrollment. But we're looking to wrap up probably at the beginning of next year. And then health security issues. So we support and contribute to the development of global reference documents, largely around surveillance, early warning, surveillance, event-based surveillance, and more recently supported assessments of countries, of country IHR or international health, the IHR 2005 capacities through, some of you may be familiar with this joint external evaluation, where external experts go into countries and help the country to assess their capacity to respond to public health emergencies. So I actually just got back from Thailand Saturday night after being there with the JEE mission. But getting on to the main part of the talk, so this is focused on this sort of integrated, well, what's really I envision sort of an integrated approach to surveillance for emerging COVID variants. You see the problem statement. So kind of the bottom line is that really not very much is known about population level SARS-CoV-2 immunity, and sort of where there is some understanding of that, little is known about what that means for future transmission. Part of the challenge or the difficulty with understanding population immunity to SARS-CoV-2 is there's just many variables that impact that, that interact with each other in a number of ways. So you have over on the right, you see here, we have a host immunogenicity. So different individuals, different age groups respond differently to antigenic stimuli, different vaccine types and combinations. The interval between vaccines is frequently different, which can influence the immune response. The number and the timing of prior infections, prior infecting strain or variant, and it appears as though the sequence of prior infections may also be important for immune imprinting. And then antibody contraction or humoral waning, so sort of the decline in immunity, particularly in antibody or humoral mediated immunity. Okay, so the aim was really to conduct a proof of concept study to see if we could leverage our existing surveillance platform to simultaneously track sort of a number of key data points for understanding current and future transmission. So number one, changing population immunological markers. When I say changing immunological markers, I'm talking about changing within the population over time, not talking about like what's happening in a single individual. Circulating viral strains or variants, and then the third point is I think probably one of the key points in this talk is understanding correlates of protection for emerging viral strains. So so new variants. A lot of the correlates of protection work that was done for COVID was done in the era prior to variants with a lot of sort of effective immune evasion capacity. So a lot of the work that was done, very nice work, based mostly on vaccine trials, but it's difficult to translate those findings into the current immunological environment. And then there's a couple of other things that that we're working on related that I'm not going to present here because it's sort of earlier stages of the work, and these are the points in grey. So epidemiological and phenotypic changes, including disease severity across the emerging strains. Specifically in the context of this, we're talking about SARS-CoV-2, and then fitness of mutations when sort of controlling for immunological pressure. So this is some sort of side projects that we are working on that actually appear fairly promising, but I'm going to focus in the talk on these 3 points at the top. Okay, so this is a cartoon sketch of the methods of what we do and how we collected the data for this sort of study / analysis. So we have patients that are enrolled through our surveillance platform in Dominican Republic, as I previously described. So these are patients who present with undifferentiated fever. If they meet enrollment criteria and they consent, then when we administer questionnaires and collect nasopharyngeal swabs and blood, both whole blood and blood for serum, and then we conduct total anti-spike antibody testing using the Roche Alexis platform. With the nasopharyngeal swabs, we test for COVID by PCR, and then those that are positive and meet some additional criteria perform genomic sequencing. Those that are negative act as the negative controls for the work that we're doing. Okay, so so the antibody testing, obviously, that provides us information about what's happening with population immune biomarkers. This is one immunoassay that we are running, but this methodology could equally be applied to different types of immunoassays. So, whether that is binding antibody assays or neutralizing assays, etc. And then the genomic sequencing we use to identify the circulating viral variants, just as many groups do. But the thing that's maybe a little bit different to what is done in most sort of surveillance systems or infrastructure is we use this case negative design and essentially compare antibody levels between those individuals that test positive by PCR versus those that test negative by PCR. And okay, and now I'll sort of run through the findings from those 3 different pieces. So the first is changes in anti-spike antibodies over time. So this, I was curious about this because we know a lot about what is happening with antibody levels and T cells after vaccination and after infection in individuals, but as I mentioned earlier, we really have very little understanding of sort of what is happening on a population level over time. So we through the methods I described, we sort of tracked what was happening amongst this specific study population. And if you look at the table entitled Table 2, we have 5 study periods. So the study or data from the study was initially collected, or we started collecting in March of 2021, and the data for the what I present here is was collected through August of 2022, so about 18 months, something like that, and divided up into five study periods. And then to the right of that, we see the number of patients or study participants who are enrolled during each of those study periods. We see the seropositivity, so the anti-spike seropositivity, the presence or absence, and the proportion here. As expected, the number goes up quite dramatically. I should say that this study period largely aligned with the rollout of the national COVID vaccination campaign in the Dominican Republic, which was launched around the end of February 2021. So most of the population were vaccine naive in advance of this study. So back to the table. So if we go right from the seropositive column, we can look at the geometric mean titers between these time periods, and we see, amongst this study population, quite dramatic increases in antibody titers over time. So almost logarithmic increases during the 3 study periods in 2021, and then some sort of flattening off in 2022, but really quite dramatic increases in antibody levels. And the same if we look not at the geometric mean titer, but at the median titer, we see a sort of similar pattern, if slightly more dramatic, but overall similar. So here we essentially take this same data that is presented in the table, but just presented visually, and in what I think is a slightly more interesting way. So if we look at the top panel A on the left, so this is a ridge plot for those who, if anybody is not familiar with it. So in panel A on the left, we have the same 5 study periods, and on the x-axis, the horizontal axis, we have antibody titers measured in binding antibody units per ml, and this is a log scale. So this is 0.1 binding antibody units, 1, 10, 100, 1,000, 10,000, etc. And so what you see, and this, each of these represents a distribution of the antibody titers amongst the population during that study period, with each of these little gray circles representing a single individual. The vertical black lines that we see here are the median values. So we can sort of see what is happening over this population over time. And then we did sort of the same thing, but stratified first by age group in plot B, and then by vaccination status over here in C. There's quite a lot in these figures, but I'll just sort of point out a couple of interesting things. So here we have the unvaccinated. So because they're unvaccinated, we can assume that all of the antibody response to everything that we see here is secondary to infections. We see progressive increases even amongst this unvaccinated population, and we see the shift in the distribution amongst the population as we move from early to mid 2021 to mid 2022. The other thing that's actually quite interesting is even within categories. So for example, if we look at the 2 vaccine doses right here, if you can all see, these are all individuals that received 2 doses of COVID vaccine prior to being enrolled. But we actually see that regardless of the fact they all have the same number of vaccines, we continue to see an increase in titers over time. This is probably due to primarily ongoing infection, The primary vaccine was the Sinovac, the whole viral inactivated vaccine that is actually not incredibly effective. So we know that there was a lot of ongoing transmission in the population. Amongst the 3 doses of the vaccine, there's just very high titers kind of across the board without a lot of big changes. And we can also sort of look at differences amongst the different age groups. We see amongst the youngest age groups that compared to the older age group, these were largely ineligible for vaccines during the study period. And we see that the majority, certainly early, would be seronegative with low antibody levels, and we see this sort of progressive shift to the right, which represents on this logarithmic scale sort of increasing titers over time. Okay, so circulating viral strains or variants, as mentioned through this surveillance platform, those are the samples that are PCR positive. A subset of those tested they're sequenced for the viral variant or clade. On the left here, what we see is a sort of a hodgepodge of different strains, alpha, gamma, iota, lambda early on, and then this green is mu, which is quite interesting because there's just not a lot of global mu transmission. This emerged out of Colombia around April or so, but didn't sort of pass or move or expand very effectively globally, potentially because of the sort of incoming Delta, which clearly outperformed the mu variant. So this yellow, dark yellow is the Delta, and then we have the Omicron. And then a long gap actually after the Omicron. There's a large Omicron surge in the Dominican Republic, and very, very little transmission. I think we identified a couple of cases in about 2.5 months or so, were PCR positive. And then later, this is BA2, BA4, BA5, and this is sort of a breakdown of that, but sort of a fairly standard sequencing and presentation of the data from that perspective. But yeah, I think of all of this, I think this next piece is sort of the most interesting. This relates to sort of correlates of protection. But the first question prior to talking about correlates of protection is, do anti-spike antibody levels track with risk of infection? So we know that neutralizing antibodies track with risk of infection. Some of the first correlates of protection papers also seem to indicate that binding antibodies actually correlated pretty well, potentially as well as pseudoviral neutralizing activity. But it hasn't been something that's been really well characterized. The focus has really largely been on neutralizing antibodies. I think largely because there's a sort of a functional rationale for why there would be this correlate of protection, as opposed to these antibodies that we're measuring that are largely binding antibodies. So this was the first question: do anti-spike antibody levels track with risk of infection? So what we did is sort of broke down the study period into phases, and on the left here we see the different phases. The pre-Delta phase, which is mu plus a number of the other variants that were circulating around that time. We have the Delta phase that was pretty clean, the Omicron BA1 phase, and then the Omicron BA2, BA4, and BA5 phase. And then we looked at all of the the individuals enrolled during that time, and their PCR status, the NAAT, just for anyone who's not clear on what that means. That's just a nucleic acid amplification test, which is just PCR test actually in this case. So we have the negative patients that were enrolled during that period. We have the positive patients that were enrolled with that period, and then we looked at the antibody levels. This is the geometric mean titer again, really to understand if there's differences. If the anti-spike antibodies track with infection, we would expect that higher antibody levels will be associated with lower risk of infection. Conversely, those that test negative, we would expect to have higher antibody levels, and those that test positive, which is what we saw across all of the strains, actually consistently, whether we looked at geometric mean titer or median titer. That was a pretty consistent picture. And then the second question was if elevated anti-spike antibodies are associated with less infection or low risk of infection, then we would expect to see some sort of biological gradient, dose response effect. So very high antibody levels will be associated with a much lower risk of infection than moderately elevated or only minimally elevated antibody levels, for example. So what we did is we binned the antibody titers into quartiles and used the first quartile as the reference, and then performed binomial multivariable regression to and generated odds ratios, with the odds ratios indicating or the odds ratios being for COVID positive test, so PCR positivity. So what is the odds ratio of being PCR positive based upon the level of antibodies, or in this case the quartile of antibodies. So this is all of the patients enrolled. It's 2,300, and we see the odds ratios decline in a fairly consistent way with what we would expect, a sort of biological gradient. Across all the samples, we see slightly different patterns across the different strains, but overall we see a similar type of picture, with substantially lower odds of a positive test amongst those in the fourth quartile versus the first quartile. Okay, so here we basically binned the antibody titers into the categories. Here we considered the antibody titers as a continuous variable, and these are the outputs of generalized additive models and visualized with the VisRec package in our so I'll sort of talk through this because there's a sort of a lot going on. So first of all, each of these are for a different variant, and on the left we have the absolute risk of infection. On the x-axis we have the anti-spike titer on a log scale. The green shading represents the anti-spike density. And so what happens as we go from mu, which is early in the study period, to delta, which is a little bit later, and BA1, so the original Omicron, a little bit later, etc. What we see is this green shading, which represents this anti-spike antibody density shifting to the right, as we go later into the study, we see the density moving over to the right, and this is the same study period, actually, these two. And so that's basically the sort of the background to what you're looking at, and then the red line is the regression line, and the gray shading, the 95% confidence interval. We see sort of different, I guess, different curves based upon a number of factors, but probably most importantly based upon how immune evasive the strain is. So if it's highly immune evasive, you imagine that it would take higher levels of antibodies before you're going to decrease the risk of infection. And that's really, in summary, that's what we see here. So quite steep risks, quite steep decline with mu. So if we're looking at the absolute risk, there's a relatively large decline, even with only moderate increase in antibody levels. Somewhat similar with Delta. If we look at BA1, we're starting to see this flatten out. If we look at BA2, it flattens out more, and BA4 and 5, it flattens out maybe even a little bit more. So this is the absolute risk. But I think what's more interesting is actually looking at the relative risk. So this is the same data, just analyzed in a different way. And so this is the relative risk relative to antibody titer of 0.4. Now, the cutoff for negative is 0.8. So essentially, for all intents and purposes, it's the relative risk relative to somebody without measurable antibodies, or below the threshold of positivity. So what we see, again, we see this pattern depending upon the immune evasibility of the variant, right? So you see a pretty steep decline, and then a flattening of the decline, and more flattening of the decline across BA2, and even more across BA4. I should say that the relative risk here is on a log scale, just to point that out. Obviously the relative risk of 1 is kind of right across the middle here. For illustrative purposes, I added in the relative risk of 0.25, which is, you can think about this as what antibody level can we expect would provide about 75% protection. This we can think about right here as a point estimate for 75% protection against infection with a mu strain that's not circulating anymore, but for illustrative purposes and for comparing across the variants, I think it's interesting to look at. So and then this is the antibody titer. So if we think this on a log scale, but the actual value is 25 here, we do the same with Delta, and we look at the antibody level, binding antibody units, that's at least the point estimate that's associated with 75% protection against infection by Delta, about 42. Obviously, these are point estimates with pretty broad confidence intervals. And then BA1, BA2, and BA4. So really, the level of antibodies required to prevent infection, or I should say associated with lower risk of infection, increases really dramatically across the Omicron, and even within the Omicron subclades, moving out to BA4 and BA5. I mean, we know that BA4 and 5 are much more highly immune evasive than even BA1, which is much more highly immune evasive than Delta, etc. But This, I think, is sort of the first work that sort of started to explore correlates of protection beyond those initial correlates of protection studies that were really done before widespread circulation of these variants that that can really evade the immune system effectively. Okay, so that's sort of a summary of where we are now. It's a bit of a work in progress, and we're still sort of fine-tuning some bits and pieces. The first piece about the antibody levels and sort of the crude associations between risk of infection and antibody levels is actually out on preprint. If anybody is interested, the link is down here. But yeah, so I guess in conclusion, we developed, but I should say that the inspiration for this actually came from a paper in the New England Journal that Mark Lipsitch was a co-author on, related to reinfection in healthcare workers in Israel, and they actually looked at measuring antibody levels at the time, either before infection, if they were part of an ongoing cohort, but some proportion had antibody levels measured at the time that they were diagnosed. And so I hadn't actually thought about this. It's not really something that people have done, or not much. And so, yeah, it was really that sort of inspiration that we sort of built off of to develop and I think expand on that approach. So we developed these methods to track temporal changes in antibody levels across this targeted population. Admittedly, this is not a representative cross-section of the population. These are patients that are presenting to healthcare facilities. But I think it almost certainly provides some insight into what is going on a population basis. We, number two, surveil for circulating viral variants. And then the last piece is estimate correlates of protection, including against emerging strains. And in fact, you know, this approach could generate correlates of protection sort of almost in near real time as new variants emerge. Second, I think we affirmed that total anti-spike binding antibody levels track closely with risk of infection across multiple strains of SARS-CoV-2. Third, and I think sort of a key point is antibodies measured when patients present for care, at least for SARS-CoV-2, appear to be a reasonable surrogate for antibody levels at the time of the initial infection. If we think that someone is exposed and infected and then they're incubating, then they become symptomatic and then they present for care, that is when we measure the antibodies at the time that they present for care. But there will be an immune response that is being generated in the interim. But it does not appear, based upon the data that we have, that the immune response is sufficient enough to muddy the picture of differences in antibodies between those that test positive for acute infection and those that test negative. We measured standard binding antibodies, but as mentioned before, this same method could be equally applied using neutralizing assays. We could measure antibody-mediated effector functions, even in certain situations. It could even be used, I think, for assessing T-cell activity if we really want to understand correlates of protection for severe disease. And I think that these methods may be applicable to other pathogens with potentially important public health implications. Zika virus, we don't think about Zika virus very much, but immunity wanes to Zika virus, and there's been a lot of births in the last 10 years, and so the susceptible population is growing. So I think we are going to see more of Zika virus in the next years. Mandurajia virus, and then pathogen X. It's sort of a generic term for anyone who's not familiar with it, with the sort of for an unknown pathogen that will emerge in the future. And I think that's that's about it. Just some key acknowledgements. So first, and I think most importantly, my fantastic collaborators in the Ministry of Public Health, Cecilia Then, up in the top left, Deputy Director of the National Epidemiology Division. To her right, Ronald Skews, he's the Director of the National Epidemiology Division, and then Isaac Sanchez, he's the Deputy Director of the National Public Health Lab. Some of my close collaborators, Adam Kaczarski from the London School of Hygiene, Tropical Medicine, Marietta Vasquez from Yale, Colleen Lau from the University of Queensland, William Duke from Umfu University, and Naomi Iliyoshi, who's a lab consultant. Christy Murray and her team, who supported the sequencing from Baylor College of Medicine, and Peter Jarlin for running all of the antibody assays from the Brigham, and that pretty much all of this work is primarily funded through the US CDC under a UO1 award, and then our team both US based and in country. So thanks very much, and yeah, very happy to take any questions you may have.
Thanks so much. That's a really fascinating talk, and I'll collect some questions. So if you raise your hand, with the Zoom function, or you can put questions in the chat. So I'll just scan and see who has questions. But while we're waiting for people to kind of collect their thoughts, maybe I'll start with one that's really kind of more on the big picture. So you mentioned towards the end your collaborations, including with the Ministry of Health in the DR. And I guess one question is just stepping away from the findings about immune response and so on. Are there policy implications that you take away from this work, either sort of for the COVID response generally or specific to the DR? Are there kind of things that could inform the COVID response that you take away from these results, or is this really a more genomic and biomedical sort of set of findings?
Yeah, no, thanks for that. Yeah, I feel quite fortunate actually that that the Ministry of Health have been really receptive, particularly around the National Serological Survey. So I had the opportunity to present a couple of times to the Minister of Health, and one time to the Vice President, those findings, and actually, as was repeated several times during that meeting with the Vice President, they actually used the results from the serological survey to guide their national policies. So they were really trying to understand how quickly they could move to open up and actually relax policies and the data, particularly from the Sero survey. Not that we were advising them one way or the other, to be frank, but yeah, it was. I wasn't involved in the discussion to make the policy, but communicated to us that that this was really key to them to have sort of high quality data they could base their decision on. So which is very gratifying, as I'm sure you are aware, in sort of academia, we do a lot of work, and so when we really see that it's being used practically from a sort of public health perspective, it's really very nice. So that's the SURV survey. For this work that we're doing right now, I really think that there is a sort of a lot of potential to translate these findings both for modeling future transmission, but also for guiding ministries of health. So if they have some reasonable understanding of what the population immune profile looks like, and if they have a reasonable idea of correlates of protection for newly emerging strains, especially if they can get that data, in near real time, I think that's incredibly valuable, to be honest. I mean, I guess I didn't talk a lot about that piece, but I that's what I would love to do, is to take this work and develop it into a pipeline, so that the data coming out is actually sort of timely and practical and usable for the ministries of health and for the government.
Great, thank you. I'll just let others chime in. Again, raise your hand with the Zoom chat, or you can just speak up if you have a question. So everybody's shy today, so I'll ask a second question just to get the conversation started. How do you interpret on your first table 2 that you showed? It looked like you were, by the end of the period of your sampling, by August 2022, you basically approached almost universal seropositivity. I think you said that's a combination of the vaccine rollout plus the plus infection, but it was that right, or should we interpret that as saying that in your setting, almost everybody had been infected, or almost everybody had been vaccinated, or some combination of the two? I guess that'd be the first question. And then second question, this was all about protection from infection, but do you have results or ongoing work about correlates of protection from hospitalization or severe, I guess you're doing this in a hospital, right, but severe disease or other kind of sequelae?
Yeah, no, that's incredibly important question. So yeah, I mean, we've started looking at this question. That the data is not as clear with hospitalization as it is with infection. I think that there's a number of reasons why this could be. Probably the most important is we're not measuring what is probably the primary driver for prevention of severe disease, which is cellular T-cell activity. So in the absence of that, I'm not sure. I think we're still looking sort of through to figure out if there's a way to, or if there's signals of associations with hospitalization, but based upon what I see so far, that hasn't been the case. And then the first question about table 2, yes. So by the last study period, I think May to August 2022, seropositivity across this group was about 96%. This could be either due to exposure. It's due to exposure to SARS-CoV-2 antigen, and so this could be either vaccination or infection, but largely people have been both vaccinated and infected, and I think probably many people infected multiple times, to be frank. So so yeah, if hopefully that answered your question.
Great, thank you. Any other questions from the audience? All right, so I think we have a few minutes. Eric, do you want to offer any kind of concluding thoughts before we wrap up, or any final words, or we wait to see if anyone jumps in with a question?
I think I would just say thanks to you, and thanks for the organizers for the offer to come and share some of the work that we do. I think that there's still more to be done in this space around what I presented, but hopefully some people found it interesting, and we really aim to make this something that is not just academic, but has sort of real public health utility is ultimately the goal here. So we'll sort of see how things pan out moving forwards. But yeah, thanks very much for hosting, and happy to take any questions if there's any.
Well, let me just, I guess, conclude by thank you again for coming. I know many others may follow up with you, and I'm sure there's a lot of follow-up that might happen offline. So thanks again for coming, and it's great to hear about this work and great to learn more about these projects. And with that, I'll close the seminar and just thank you all for coming.
Great. Thanks, Kevin.
Thanks, everyone.